Okay, let me give you a short introduction or orientation to the preceptorial, or what we call case presentation and discussion with the journal appraisal. Okay. So we allotted 2.5 hours. Our platform will be the Zoom. Okay. So I'll be your facilitator this morning. Okay. My name is Dr. Rinaldo Ong Hoson. Okay. So we have Julian Mendoza, John Roger Silva, Ira May Simborio, Stephanie Maysor, Cian Austin C., Carol Timothy Tan. Now, the learning objectives will be the following. Given the patient, the mentees should be able to provide the details, clinical data clearly and concisely. I would like to add relevantly. Then to provide a good history and present complete physical examination as one would proceed in a bedside preceptorial. Again, another additional emphasis will be relevantly. Give differential diagnosis and explain on how the group arrived at the primary working diagnosis. So a parameter that we'll be using here will be efficiency. Explain the pathophysiology of the disease at hand and may include theoretical data or possible existing epidemiology of it. Okay. Again, additional parameter will be relevant. Provide options for additional diagnostic maneuvers or studies. Why this is in red, I added it because I don't think it's seen in your syllabus on the learning objectives. I just added it. Then provide surgical plan or medical plans or other treatment options. Okay. If the patient does not need surgery, so you have to provide the medical plan. Then lastly, present a journal appraisal of a relevant clinical question regarding the management of the patient. So are the learning objectives clear? And do we agree on this? Clear?
Yes, po, sir.
Yes, po, sir.
So basically, this will be the the evaluation that the areas that I'll be evaluating you on will be the following: history, physical examination, differential diagnosis, diagnostics, treatment plan, a relevant journal later on, then psychosocial concern, then questions and answers this means that will be a participation in the discussion, communication skills, and presentations. So in the history and physical examination, you should be able to enumerate and discuss the pertinent negatives and positives. Okay. As I said, relevant. Okay. In the history and PE, that will lead to a diagnosis. Then the primary working impression and differentials. That's why here I use the primary clinical impression, and the differential will be your secondary clinical impression. Okay. Just two, okay, or at most three. Okay. Not a rundown of all possible differentials. Okay. For the differentials, you just choose the second most probable. Okay. So here you summarize the salient feature of the case, arrives and justify the primary working impression, and discuss the differential diagnosis. Then as to the plan of management, which includes diagnostic and preparation if it's for the patients for surgery. Okay. Formulate a plan of diagnostic workup to confirm the primary impression according to standards of care with consideration for cost efficiency. Plan of management, therapeutics, surgery. Decide a viable plan for therapeutic approach, whether surgical or medical, or both, and explains the rationale why you choose this surgical plan or medical plan, putting in more focus on the surgical plan if it's a surgical plan. Then post-op complications, prognosis, and surveillance. Explain concisely what to watch out for in the immediate post-operative course. Okay. Usually we use the 30 days cutoff. Okay. Any complications that occur within the 30 days are still part of the are still considered surgical complications or post-operative complications. And then also considerations regarding prognosis and surveillance. Surveillance if it's cancer. Okay, agree? Everything clear?
Yes po, sir.
So as to the criteria for the journal appraisal, we will be using this criteria, research question based on the clinical problems related to the management of the case, description on how the article was sought, 5 points, summary for the journal, and then journal appraisal. I think you have a checklist, okay, based on the type of study that you have chosen. So the grading will be individual rather than a group grading. So mainly through active participation by each one of you, through answering questions of facilitator. I might be asking questions, throwing questions to you just to stimulate your learning. And then you can also ask me questions. Okay? So I would recommend that you ask me at least 2 questions. Okay? We consider mentee's contribution to the case report and journal appraisal. Okay, so I will ask May to give me a rundown of your individual contribution to the case discussion and journal appraisal. So as to the faculty evaluation, so the teacher, you will evaluate me in terms of whether I've explained the objectives, expectations, and various requirements of the course, which I think I got the perfect score now after the several previous slides. Number 2, encourages students to think critically or creatively, communicates clearly, answers students' questions clearly and adequately, is able to help the students understand the complex ideas related to the subject matter, and uses engaging and helpful learning exercises and activities, relates the subject matter to issues and developments in the discipline and or real-life concerns. So we might be talking about community issues here. Encourages students to participate in the discussions and activities, make himself, herself available for consultation. So I'm available online. Okay. Sometimes I go to the hospital, PGH only once a week, but you can easily reach me through online, Viber, or Facebook. Okay. Encourages students to express their ideas and viewpoints, and communicates and interacts with students in a positive way. Show respects for student diversity and individual differences. So I know you came from different schools. That's why I asked for this, so that it's not a discriminating students from other schools. I just want to know where you're coming from so that I can tailor my teaching towards your towards in consideration of your diversity in terms of your background. Okay. Number 13, makes full use of the required hours of learning, so 2.5 hours. Okay. Provide fair and timely feedback on students' performance. And then lastly, uses clear criteria to evaluate the student performance. Okay. So I just use what is given to us by the department, okay, how to evaluate the students. Okay. So this is another part of the assessment that you have to do after the session in relation to your learning objective, learning experience in this class, in this Zoom class. What does your teacher do that you find very helpful or effective? How do you think can the teaching in this class be improved, enhance your learning experience, and how can the teacher utilize technology more efficiently to enhance your learning? So this is applicable here because we're using Zoom. If it's face-to-face, it's still applicable. Probably Example would be the use of videos and other online learning resources. Okay, but for the moment, it's using the Zoom technology. So make himself available for consultation. As I said, I have Facebook account, 2 accounts here, and then my email address is here, my cell phone's here. Okay. So now I want to tell you that I've given you a video on the patient management process and overview. So I hope all of you have read it. Okay, and I've seen I got the report on the late last night, but I was about to sleep already, so I just took a look this morning. So I think you have followed the guidelines that I gave you, okay, and the patient management process. Okay. So at the end of the session later on, I will be giving you a online, I call it online learning cum evaluation test exercise, which you will answer. Okay, so try to get a perfect score given with 2 tries, 3 tries, or 4 tries. Okay, okay. So get a perfect score for mastery of learning. Then if you pass the OLETE, if you get a perfect score, then I'm going to give you a certificate of commitment and accomplishment. Okay. So this is basically the framework that we'll be using for today. Okay. So any questions? Everything's clear?
Yes po, sir.
Okay. Wait, before I forget, okay, so I placed the link in the chat box already because I might forget it later on. Okay, so what we're going to do, you prepared a paper. I suppose you have a PowerPoint, right? May, you have a PowerPoint or slide presentation. So I will just you just go through it all straight directly all the way down up to the journal. Then I will just jot down all my questions now, and then we will just discuss it. Okay, and I'll be answering some of my questions during the open forum. Okay, okay, is that clear? Okay.
Yes, sir.
Sige. I'll try not to interrupt you. You just finish your presentation, but I'll just jot down my notes in my paper. Okay. Okay. So take it away.
Okay, sir. I'll share screen po. Okay, so good morning. We're Block W, and we'll be presenting a case on breast cancer. So here's the outline of our presentation following the format given to us. So this is the case of SR, a 59-year-old female married housewife Roman Catholic from Quezon City, coming in with a chief complaint of a palpable mass on her left breast. So she had a 25-year history of a breast mass, a 2 by 1 centimeter ovoid, well delineated firm mass on the left breast on the 12 o'clock position. It was movable, non-tender, without associated skin changes, without fever, and without weight loss. So there were no symptoms bothering the patient at this time, so she did not take any medications or seek consult for the mass. And in the interim, allegedly, there was no change in size and no new symptoms. Until 2 years prior to admission, there was rapid enlargement of the mass until about 8.5 centimeters. At this point, she said the mass was non-movable, was tender, and there was a slight erythema over the mass on the skin. But there was no ulceration or nipple discharge. So she consulted at PGH OPD, where an ultrasound was done showing BIRADS 5, and eventually a core needle biopsy was done showing invasive carcinoma. So this was her diagnosis at the time. Breast cancer left at least stage 3B with a clinical staging of T4N2MX. And she was advised neoadjuvant chemotherapy followed by surgery. So 9 months prior to admission, she started the 8 cycles of neoadjuvant chemotherapy. So starting with doxorubicin and cyclophosphamide 4 cycles, then paclitaxel 4 cycles. And she was eventually found to have complete clinical response with a decrease in size of the mass from 8 by 7 cm to about 4 by 3 cm. And now the patient is admitted for definitive surgery under our service, the GS1. So for the ancillary history, the patient is a known hypertensive with maintenance medications, also a known diabetic, also with maintenance medications, but not insulin requiring. She has no history of other cancers. In her family history, there's note of thyroid cancer, but no other cancer. So important to note the pertinent negatives, no history of breast cancer or ovarian cancer in the family of this patient. So personal social history was unremarkable, as well as the obstetric and gynecologic history, aside from the IUD use in the 1990s. No other contraceptive use. So on the PE on admission, this was done via chart review. Since we were not at the ER when this patient was admitted there. So there was a 4 by 3 centimeter left breast mass, movable, non-tender, with no palpable nodes, with nipple retraction on the left. And the rest of the PE was unremarkable. So here we have the pictures of the patient on admission. We can observe the breast asymmetry and nipple retraction, as well as the location of the mass as encircled here. So this was the PE that we were able to do. We saw the patient already on post-op day 1. So here, to summarize, here are the pertinent points in the history and the PE. So she presented with a 25-year history of a gradually enlarging left breast mass, movable, non-tender, with no skin changes. So at first, it was a slow-growing mass with signs not highly suggestive of malignancy. But a breast mass in a 59-year-old female may increase the likelihood of malignancy. And there was also no fever and unintentional weight loss, so there were no constitutional symptoms of malignancy. However, the enlargement of the mass 2 years prior to admission to 8.5 cm and being fixed tender with erythema could present with signs suspicious for malignancy. And the 4 by 3 cm left breast mass, this was the PE after 8 cycles of neoadjuvant therapy, so indicating a clinical response to the medical management. And there were no palpable nodes, so no clinically observable signs of lymphatic spread. There was also no cough or dyspnea on revealed symptoms, and on the PE there was clear breath sounds, so no clinical signs of lung metastasis.
So for our clinical diagnosis po, our primary clinical diagnosis is breast mass. Sorry. So the patient, just like what Jules said, the patient is a 59-year-old female who presented with a 25-year history of a gradually enlarging left breast mass, movable and tender, and initially without skin changes but with progressive enlargement of the mass. Noted with pain with overlying erythema without ulcerations, nor nipple discharges, but with nipple retraction. So for the clinical diagnosis, our primary clinical diagnosis is breast cancer, left at least stage 3B, clinically po T4 and 2MX. Then post-chemo, it's 2A, clinical T2 and 0MX po. And for the secondary clinical diagnosis, it's benign breast mass po left. So for the clinical diagnosis, we followed the NCCN guidelines for, next slide please. we follow the NCCN guidelines for patients who are symptomatic. Next slide, please. Symptomatic, and then who presents with palpable symptoms greater than 30 years old. So after pull this one, next slide, please. So for patients with palpable breast mass greater than 30 years old, a mammogram and breast ultrasound is recommended, followed by core needle biopsy for patients with BI-RADS score of 4, which are suspicious of malignancy, and 5, which is highly suggestive of malignancy. And since for our patient, her BI-RADS score po is 5 initially, so a core needle biopsy was done, which showed, next slide please, which showed the histopath results of a invasive malignant carcinoma. So for the clinical staging of the breast mass, we use for the clinical stage of breast cancer is primarily determined through physical examination of the skin, breast tissues, and regional lymph nodes. So for the clinical staging, ginamit po namin is PNM staging for the breast cancer. So for the size of the tumor, initially at first, before the neoadjuvant chemotherapy, the tumor is around 8.5 cm, which is around 80 millimeter. And it's already showing skin serous polyethylene and nipple retractions, which will automatically fall po at T4B. And then for the lymph nodes, clinical lymph nodes naman po, disclaimer lang, sir, we weren't able to palpate the lymph nodes during the time that we do our physical examination. But upon chart review, the patient was initially diagnosed with N2 for the lymph nodes. For the metastasis, there's no current workup, and so it's we're unable to stage it for the clinical diagnosis, stage grouping, so the patient will at least fall for stage 3B. Stage 3B po, using the PNMA staging. So for our primary working impression, next slide please. So for our primary working impression, it is breast cancer left, at least stage 3B po, clinical T4 and 2 MX, and then after the neoadjuvant chemotherapy, it's already 2A with a stage T2 and 0 MX po.
So for the paraclinical diagnostic procedures, I'll just give a quick review po ng primary and secondary clinical diagnosis natin earlier. The primary one was, as mentioned, breast cancer left at least stage 3B, C4T2, CT4 and 2 MX, which became 2A, CT2 and 0 MX after neoadjuvant chemotherapy. For degree of certainty, I put 95%. I didn't want to put 100% kahit biopsy proven po siya. Kasi parang parang I read po na there's no such diagnostic test na 100% certain sa accuracy po. And then, so 95 is pretty high na po for me. And then, for secondary diagnosis naman po, as mentioned earlier, it's benign breast mass left, which I put as 5 kasi nga biopsy proven na po siya. So it's much less likely for it to be benign breast mass. So next slide, please. So for the paraclinical diagnostic procedures po, for this patient, most of the procedures have already been performed. So I'll just run through po the benefits, the risk, the cost, and the availability of the tests done on the patient. The first test done po for our patient actually was a breast ultrasound. Used for imaging po the breast mass. As for the risk po, it's non-invasive. And actually yung cost niya po according sa BCC is 810 pesos, and it's available naman po everywhere. Then after breast ultrasound po, our patient underwent core needle biopsy to confirm po yung diagnosis ng breast cancer. And as for the risks of core needle biopsy, it's an invasive procedure and it comes with a risk of bleeding. According sa BCC po, ang cost ng ang core needle biopsy ngayon is 345 and it's also available po sa PGH. After core needle biopsy, her samples po were sent for immunohistochemistry, which for ERPR, HER2 new status, which will guide treatment later on if positive or negative, that are the drugs that we will use for chemotherapy, or if we can use hormonal or anti-HER2 receptor drugs. This will depend po on the immunohistochemistry results. And according sa BCC po, ang price po ng IHC is 4,360 po, and it's available din po sa lab natin dyan. And a mammogram was actually done later on after niya na po ma-diagnose as a baseline imaging po prior to starting neoadjuvant chemotherapy po ng patient. As for the risk, mammogram is non-invasive, pero dahil X-ray po, there is risk po for there is radiation exposure involved. Ang cost po ng mammogram is 1,580 po dyan sa PGH, and it's also available po sa ating hospital institution. Next slide, please. So ito po yung results ng mga ancillary procedures done on our patient. For breast ultrasound, there is an irregularly shaped heterogeneous, predominantly hypoechoic focus with spiculated margins, which measures approximately 4.8 by 4.6 by 3.4 centimeters. This was done in March last year po, prior pa po niya ma-diagnose via histopath and prior niya pa po mag-start ng neoadjuvant therapy. So by yung mass po ng patient natin is hypoechoic, which means it's high density, and not to mention it's also irregularly shaped with spiculated margins, which are all features that are suggestive of malignancy. If we are looking for a benign, on the other hand po, if a mass is benign, it's more likely to present as round po and well circumscribed. And as for the impression nga po of the breast ultrasound of our patient, it's breast mass left by BIRADS 5, which is assessed as highly suggestive of malignancy, and the likelihood of cancer is more than or equal to 95%. So to confirm the result of our BIRADS, the patient underwent core needle biopsy, and the result to determine the type of cancer, if meron nga po talagang cancer yung ating patient. And the result of the core needle biopsy nga niya po last year is invasive carcinoma of the breast left. Next slide, please. Yung mammography po was done after na po nung core needle biopsy niya, as a baseline po prior niya, kasi she was advised niyo adjuvant chemotherapy po and surgery. So this mammogram po was done, and ito po yung result: high density mass seen in the left breast with surrounding spiculations and angular margins. It is surrounded with periareolar skin thickening and nipple retraction, as well as skin retraction along the left upper outer quadrant. So these are also features suggestive nga po of malignancy, as seen in the impression nga po sa mammography. BIRADS 6 na po yung grade niya dito because her breast mass was already known to be biopsy proven malignant po. And yung results niya po yung samples niya po, slides for biopsy, were sent for immunohistochemistry, and she turned out to be ER positive, PR positive, and HER2 new negative. So for our patient, pwede po siyang undergo ng hormonal therapy later on. And since our patient is 59-year-old, probably an aromatase inhibitor po, like anastrozole or letrozole. And HER2 new negative, so less likely na gumamit po ng trastuzumab. Next slide, please.
All right po. Now for the treatment po, next slide please. Given the pre-treatment diagnosis na po of breast cancer left stage 3B, T4, right, stage 3B, and then given the biopsy results as well. So I'm gonna look at it from the perspective of some of the patient na hindi pa siya na-treat. Kasi again, we received the patient na post-chemo already. So, pero initially, ano yata yung ginawa sa kanya. So, yung goals of treatment, next slide, would be to reduce the size of the breast tumor because it's, T3B is quite big. And then to cure the patient of the breast cancer, and then to prevent recurrence also of the breast cancer, so the patient is disease-free completely. And then next slide, please. So deciding on the treatment modality, so we also use the NCCN guidelines for invasive breast cancer. And again, considering our patients' clinical staging of T4B and 2MX, we first want to determine if preoperative systemic therapy would be considered for our patient. So we need to parang see the criteria for preoperative systemic therapy. So we followed it. Next slide, please. This slide shows the principles of preoperative systemic therapy. Our patient is a candidate. Shows that our patient is a candidate for preoperative systemic therapy because she has an inoperable CT4 tumor, and also at this point, since the patient is still stable, parang definitive surgery could also still be delayed naman po. Next slide, please. So again, based on the guidelines, so now that we have considered, we're now considering preoperative systemic therapy. We now want to look at additional workup before actually initiating it. So next slide, please. So, we need to follow these additional workups shown that weren't done yet. So, for example, chest abdominal CT scan, although a bone scan was done, but parang additional workup should be done, especially for the metastatic workup, so that we know if the patient could potentially have metastasis, thus upstaging her. Then given that the patient has, again, locally extensive T4 tumor, the breast CA may now be considered quite big, and we look to the preoperative systemic na parang inoperable kasi T4 already invading the skin. So next slide, please. So yes, now we consider preoperative systemic therapy. Next slide. Following the algorithm for the specific regimen, given that the patient is HER2 negative, we followed the preferred regimen in the slide and chose to do the dose-dense doxorubicin and cyclophosphamide followed by paclitaxel for 4 cycles, as shown in the history a while ago. This decreased the size, as mentioned earlier, also the T2N0M0 clinically, which is now more operable. So next slide, please. So I'm going to talking about this now, I'll talk about the benefit, risk, cost, availability. So the benefit of this neoadjuvant chemotherapy, it allows for breast conservation, allows inoperable tumors to be more operable. Treatment response could help with prognostication because if the response is very good, it might give it's a good prognostic factor for the patient. And then if the patient allows time for also genetic testing and for just decision making for the definitive treatment as well. And then the risk though is possible over treatment if clinical stage is overestimated, and then also possible under treatment with local regional with radiotherapy if clinical stage is underestimated, and then possibility of disease progression during preoperative systemic therapy, especially if the patient's not responding. Then of course there's side effects for each drug. So doxorubicin has side effects of fatigue, alopecia, nausea, vomiting, oral sores. Cyclophosphamide also and paclitaxel has their own set of side effects. And then the cost, it varies per institution, but from my research it's around 20 to 120,000 per session. Then for 4 sessions pa po, so that would be around 80 to 480,000 for 4 cycles. And then, but this is available in PGH, and thankfully, there are ways that our patients are able to get financial support for these. And also, it's available in other institutions as well, as like St. Luke's, Asian, and Medical City. Next slide, please. So we gave chemotherapy. So we checked if the response was good, and it was. And so we now look to local regional treatment. So it needs to be decided whether breast conservation surgery or a kind of mastectomy should be done naman po, as can be seen here. So discussing the benefits and risk with the patient is also important to decide. So I move on to the next slide, where I try to show that the benefits and risk. So when you talk about the modified radical mastectomy specifically, or although that this kind of falls for many of the mastectomies in general, so the benefit would be to really eliminate breast cancer tissue by really removing the lesions and adjacent breast tissues of the breast cancer. Also, for MRM, we also look at the nodes. We try to remove as many of them, axillary nodes. We try to remove many of them as well. And then there is those that there's a large wound. There's also, of course, the possible surgical complications that may come with it, bleeding, infection, and maybe also psychological consequences of having one of your breasts totally removed. And then the cost is around, from a around 50 to 250,000, depending on the institution and other factors that will come into play. Okay, then, but this is available in PGH as our patient went through it. Then for breast conservation therapy naman po, so we could consider a lumpectomy with sentinel lymph node biopsy, given that there is a significant reduction of the size, and clinically, T2, N0, M0, it seems like. So better cosmetic outcome, of course, and it's less radical removal of the breast are good benefits of it, but the risk would be may need to operate on the patient again in the future if may positive margins, for example, or if I'm not saying here din po na walang recurrence yung modified MRM, so may possible din na magka-recurrence also with the breast conservation therapy. So sorry, I should have added that to the risk of MRM as well. The cost though also ranges based on my research to 80,000 to 275,000, and it's also available in our institution as well as other hospitals with trained surgeons and the facilities, right? Next slide, please. So deciding on treatment modality. So after the operation that's done, we usually move to adjuvant systemic therapy together with post-operative radiation of the chest wall and regional nodes, or the whole breast radiation. So next slide, please. So for adjuvant therapy, given that the patient is HR positive and HER2 negative, the systemic therapy would likely be adjuvant endocrine therapy. However, this is still pending also final histopathological result to further clarify that. So what does that look like? Next slide, please. So since the patient is, again, HR positive, adjuvant endocrine therapy may likely be given in the form of aromatase inhibitors such as letrozole, anastrozole, and exemestane for 5 years. And then tamoxifen could also be used. However, again, this is also pending a final histopathology, which should ideally include a gene assay test, but due to financial constraints and access, this is unlikely to be done for all our patients. Next slide, please. And then, so for this non-operative adjuvant therapy in the form of aromatase inhibitors and radiation therapy, so of course, the benefit is to just eliminate the breast cancer completely. Even whatever that may remain, especially if there's like nodal invasion papala. But the risk, of course, is that all of these drugs have their own side effects, and also radiation therapy has its own side effects, as mentioned here in the column on risk. And then for the cost, parang on my research po, for example, letrozole would cost 343 per tablet once per day, then for 5 years, so that would be around 625,000 or 626,000 for 5 years. Then there's radiation therapy, where it costs around 3,000 per session times 5 days, depending on the institution as well. So it can cost around 75 to 90,000. But these are again available in PGH, and our patients are able to benefit from financial aid for these. Next slide, please. So when we want to, in terms of evaluating the result or outcome of the proposed treatment, parang our from all of this, we hope that the patient would be cancer-free after everything, and there would be no recurrence of the cancer, and as well as that the patient will be able to return to pre-morbid function po. Yun po. Next slide.
So to continue, sir, the next question was if data are available, present the treatment procedures done on the patient and their outcome. As stated earlier, the patient underwent neoadjuvant therapy for 8 cycles, 4 cycles of doxorubicin and cyclophosphamide AC, and 4 cycles of paclitaxel. The outcome of which the patient had complete clinical response, and there was noted interval decrease of the size of the breast mass from 8 by 7 centimeters to about 4.3 centimeters. After which the patient was advised for admission for surgery. So she underwent modified radical mastectomy of the left breast, wherein intraoperatively there was no residual tumor, no enlarged lymph nodes, and the breast cancer was downstaged from breast cancer left stage 3B, clinical T4N1M0 to clinical T0N0M0. However, 1 week after the surgery, the histopathologic findings revealed pathologic stage 3A showing pathologic T2 and 2AMX po. Next slide, please. So this is the histopathologic findings of our patient po. Next slide. So for the prevention and health promotion, so for the final diagnosis, our patient has breast cancer left, stage 3A, based on the latest histopathologic findings, T2 and 2AMX. Since the patient is still undergoing metastatic workup, we cannot identify pa po the part of the staging po. She's also status post doxorubicin and cyclophosphamide AC 4 cycles, paclitaxel 4 cycles, and she has hypertension stage 2, type 2 diabetes mellitus uncontrolled since the patient showed HbA1c result of 9.4 and ECOG scoring of 0, which means that the patient is full active and able to carry on all pre-disease performance without restrictions. Next slide, please. So for the prevention and of disease and health promotion, so for our patient, after her surgery, she is then advised adjuvant therapy and radiation therapy. So she must follow the recommended regimen to decrease chances of tumor recurrence and complete her treatment. Also, you should advise her on proper wound care of post-operative site. And also, aside from her breast cancer treatment, she should be advised on taking her maintenance medications for other comorbidities such as hypertension and diabetes. So she should also be seen by the ophthalmology department for baseline fundoscopy for possible diabetic or hypertensive retinopathy. So for these patients, relatives, and female children, they should be advised on early screening and early detection of breast cancer, which can be simplified by what is shown in this infographics po. I got this infographics from the Department of Health user. So they showed like a simple way on how to what are the signs and symptoms of breast cancer and how they can prevent it, and how to do breast self-examination po. So also, all women should also be advised to have their baseline mammogram starting at 40 years old, every 1 to 2 years, with or without clinical breast exam, or as early as 35 years old if with first-degree relatives with breast cancer. Next slide, please. So for women with personal or family history of breast, ovarian, tubal, or peritoneal cancer, or have an ancestry associated with breast cancer susceptibility 1 and 2, gene mutations are advised to undergo genetic counseling, genetic risk assessment, and BRCA mutation testing, such as seen in this slide. So any of the following indicates a risk of having BRCA mutation: personal or family history of breast cancer diagnosed under age of 50, personal or family history of ovarian cancer at any age, women of Ashkenazi Jewish ancestry with breast or ovarian cancer at any age, regardless of family history, affected relatives with a known BRCA1 or BRCA2 mutation, bilateral breast cancer, especially if diagnosed at an early age, breast and ovarian cancer in the same person. And also, it should be noted to recommend annual breast MRI screening as an adjunct to mammography for those with BRCA mutation and those with first degree relative of BRCA carrier but was untested before po. Next slide, please. So for psychosocial concerns, since the patient has underwent mastectomy, she may have body image concerns such as asymmetric breast, so she may be offered breast reconstruction and referred to plastics division if she would want to, or other measures to preserve body image po. Also, the patient may have concerns on financial and moral support, where wherein this is an integral part in any patient requiring long-term treatment such as cancer. Thus, we should must determine her means of financial support and moral support, such as family members, caregiver, whom she depends on, especially during her follow-up adjuvant therapy and radiation therapy. Aside from this, the patient may also get to know other patients, breast cancer patients, like those in BCC, for her to feel that she is not alone in this fight for breast cancer po. Also, for treatment continuity, this also related to financial and moral support. So we must determine from the patient who will be with her during her therapy sessions, how she will sustain coming back for frequent follow-ups and further workups, such as metastatic workup. She may also be advised to ask from help from sa mga officials po ng town nila, or such as dito sa atin we have medical social services if as we have seen kanina, the costs of the metastatic workup and her medications are expensive po. So that is all for my part po, sir.
So to end our discussion po, we'll be discussing a journal. So after we saw the patient, after we studied the patient po, we came up with a question. Next slide, please. Basically, we wanted to find out, since the patient although the patient was node positive and had the T4B disease, stage 3B, we wanted to find out the possibility of how effective a lumpectomy plus radiotherapy would be compared to a mastectomy alone po. So we came up with the clinical question, among adult patients with breast cancer who underwent neoadjuvant chemotherapy, how effective is breast conservation therapy compared to mastectomy in improving disease-free survival rate? So our population was adult patients with breast cancer who underwent neoadjuvant chemotherapy. Our exposure was breast conservation therapy plus radiotherapy, which was summarized to breast conservation therapy because it is standard of care to receive radiotherapy after breast conservation therapy. Our control was a mastectomy, which is the alternative treatment, and our outcome was disease-free survival rate. So when we put this into PubMed, the advanced search, next please, we were able to find 11 articles using this search, and applying a filter of 2018 to 2023 to have the more recent studies, the more recent studies featured in our search. So we ended up with 11 studies, and from the 11 studies, we found this journal. Next slide, please. Entitled Breast Conservation Therapy After Neoadjuvant Chemotherapy Does Not Compromise 10-Year Breast Cancer Specific Mortality. by Doctors Arlo and et al. It was published in 2021 po. So comparing to appraise the directness of the study, we compared the PECO that we came up with and the PECO of the article. So the population that the article featured was patients with the primary breast cancer diagnosed between 1998 to 2003 who underwent neoadjuvant chemotherapy. The exposure was breast conservation therapy plus radiotherapy. The control was mastectomy only, and the outcome was 10-year breast cancer specific mortality. Though the initial outcome that we wanted to appraise was disease-free survival, we believe that 10-year breast cancer specific mortality is also a very direct and a very applicable outcome for this patient. And so we found that this article is direct enough and is directly applicable to our patient. So we continued the appraisal, moving on. So to appraise validity naman, we followed the guide questions prescribed by Dr. Dance in Painless EBM. So the first question for an article on therapy, or in appraising an article on therapy, is were the patients randomly assigned to treatment groups? And since the study is a retrospective cohort study and not a randomized clinical trial, the patients were not randomly assigned to the treatment groups. In fact, the study was based on the New Jersey State Cancer Registry with patients with a primary breast cancer diagnosed between 1998 and 2003. And yun po, because of the nature of the study and because they used the database search, they were not able to use randomization. Next slide, please. So the baseline characteristics of the patients in the study were not initially the same, especially the patients with the breast conservation therapy group. Most of the patients who underwent breast conservation therapy from that they found in the database had earlier summary stage and less lymph node involvement. However, they tried to compensate for this statistically using logistic regression and and sample matching. So they use propensity scoring to match 220 patients from the initial group of 400 plus on each group. And then after propensity matching, propensity score matching, they were able to create a matched data set with 220 patients per group, with a total of 440 patients. And the differences were grouped, including summary stage and at diagnosis, and the lymph node involvement were no longer statistically significant after propensity adjustment. Therefore, though the baseline characteristics were not similar at the start of the trial, at the start of the study, they were able to apply statistical manipulation such that the baseline characteristics of the data sets of the patients and the data sets that they were analyzing were not statistically significantly different. Next slide, please. So allocation was not concealed because it was a retrospective cohort study. Next slide, please. And patients were not blinded to treatment assignment because it's basically impossible to ethically blind patients as to whether they receive breast conservation therapy or mastectomy, given the nature of the management done. Also, patients were not blinded as this was again a retrospective cohort study. Next slide, please. Caregivers were also not blinded to treatment, regardless of if this was a retrospective cohort study or a randomized clinical trial. It's impossible to blind a physician or caregiver, especially the person performing the surgery, as to what procedure they are performing on the patient. Next slide, please. So, once again, this is not applicable. However, patients were analyzed in the groups that they were originally placed in. So, so the statistical analysis was grouped according to the therapy that was performed and the initial baseline characteristics, which I'll discuss later on. So, next slide. And the follow-up rate was adequate. The median follow-up rate was 110.5 months for the BCS group and 106.0 months for the mastectomy patients, which is very close to 10 years. So overall, although a lot of the guide questions prescribed by Painless EBM by Dr. Dance were not necessarily applicable to the study, we believe that the statistical methods that were used by the study creates a very strong level of validity for the study and creates and leads to very valid results by the study, which can be used which we believe can be used to guide our management for this patient or similar patients in the future. So to appraise applicability, I'll show you the next slide, please. So this is the table listing the baseline characteristics of the female breast cancer patients with chemotherapy following surgery, followed by surgery from 1998 to 2003 in New Jersey. It covers female patients, which is applicable to our patient. They're 26.8 of the breast conservation therapy group and 25.6% of the mastectomy group were within the age group of our patient, which is 55 to 64, given that our patient is 59 years old. Their socioeconomic status of the patients, the study featured patients from various socioeconomic statuses, including patients who are below the poverty line, and those who are less fortunate, and those who are not covered by healthcare insurance, which is very relevant in the States. Although there are socioeconomic factors that would challenge the access, that would be different with regards to access to medication and access to treatment options in the States versus the Philippines. We believe that given the variety and the range of socioeconomic statuses of the patients that were involved in the study, or that were found in the directory that was used for the study, we believe that it shows, given that range, that question of access is not as big a challenge with regards it's not a big a challenge to the applicability of the study if we were to apply it to a patient here in the Philippines. For summary stage and lymph node involvements and estrogen receptor and progesterone receptor assays, once again, the patients were the data sets were statistically manipulated such that the groups would not be statistically significant. And so with regards to comorbidities and pathology, the study is applicable to our patient. The only criteria rather that this study might not be completely applicable to would be race. Since the study was based in New Jersey, the directory used was from New Jersey. The study primarily features white and black individuals, Caucasian and black individuals, and very few Asians were included in the study. However, given the rest of the criteria were applicable to the patient, we believe that overall the study is still applicable to our patient. Next slide, please. So now moving on to appraising results. So this is a survival rate curve. I believe it's called the Kaplan-Meier curve or something like that. I forgot the exact name. Yeah, Kaplan-Meier survival curve of the featuring breast cancer specific survival rate for breast cancer patients treated with chemotherapy followed by breast conservation therapy versus mastectomy. So looking at this study, looking at this chart, we are able to note that the treatment group with the breast conservation therapy had a significantly better survival curve and a higher survival probability over time compared to patients who received mastectomy only. Next slide, please. So the study also divides. The study also is able to. The study also divides the groups into node positive and node negative groups for patients who received breast conservation therapy or mastectomy, and comparing node negative groups, that would be the blue line and the red line. Node negative patients who received breast conservation therapy were noted to have a better survival curve and better survival probability at 10 years compared to patients who receive mastectomy only if they are node negative. However, this was not noted to be statistically significant until the 10-year mark. For node positive naman po, patients who received breast conservation therapy who were node positive were also noted to have better outcomes than patients who were node positive who received mastectomy only. However, this was not statistically significant. Next slide, please. using the raw data presented in the study, we also wanted to look into the 10-year mortality rate, since this was the original outcome we wanted to appraise. And we noted that for node-negative patients in the breast conservation therapy group, the 10-year mortality rate was 0.57 or 57%. And in the mastectomy group, the node-negative patient 10-year mortality rate was 66%. Whereas in node-positive patients, the 10-year mortality rate was 73% for the breast conservation therapy group and also 73% for the mastectomy group. Whereas for all patients who underwent breast conservation therapy, the 10-year mortality rate was 58%. And for all patients who underwent mastectomy, the 10-year mortality rate was 61%. So this data alone does not really help us too much. So we took a step further and used risk and evaluated the risk rate or the hazard ratios using these mortality rates. Next slide, please. So applying the statistical protocol proposed by Peñas EBM, again by Dr. Dance, the risk for the control group was 61%, which is the 10-year mortality rate of the mastectomy group, while the risk for the treatment group is 58%, which is the 10-year mortality rate of the BCT group. This represents a relative risk of 95%, meaning that the 10-year, you are 95% as likely to pass away at 10 years if you receive breast conservation therapy versus mastectomy. The absolute risk reduction is 3%, and the relative risk reduction is 4.9%. So this represents a data set that is not statistically significantly different. And given this, the 4.9% relative risk reduction and the 3% absolute risk reduction suggests together with the results of the study that were presented by the study, suggests that breast conservation therapy is in general non-inferior to mastectomy alone. Next slide, please. We also decided to look into the node positive group, given that our patient was node positive, and we found that there is an absolute risk reduction of 0% and a relative risk reduction of 0%. So they are basically the same when it comes to 10-year mortality, at least according to this study. Next slide, please. So on the other hand, the patient was evaluating the survival rates as a whole and not just the mortality rates. So the survival rate meaning the survival over time. The study was able to establish a hazard ratio of 0.46 and a confidence interval of 95%. 95% with the hazard ratio ranging from 0.27 to 0.78. So overall, the hazard ratios on the confidence interval and the range of hazard ratios observed in the study are net positive in the sense that there is better survival in the BCT group over the mastectomy group. However, the size is not the size of the positive effect is not statistically significant enough to be able to say that the BCT, that breast conservation therapy plus radiotherapy is statistically significantly superior to mastectomy alone. However, it is able to establish that it is non-inferior. Next slide, please. So once again, the treatment effect was it had a 95% confidence interval, and the range was 0.27 to 0.78 for the hazard ratio. And once again, it was found to be non-inferior for lymph node positive breast cancer patients and patients with breast cancer in general. Next slide, please. So to individualize the results, we tried to compute for the number needed to treat, and we found that for every 33 breast cancer patients who received neoadjuvant chemotherapy and were treated with breast conservation therapy plus radiotherapy instead of mastectomy alone, meaning mastectomy without radiotherapy, one more patient will survive in 10 years. Next slide, please. And for node positive patients, we were unable to compute for a number needed to treat, given that there is no absolute risk. The absolute risk reduction for this group is 0%. However, we believe that there is still benefit with regards to the mental health and the body image of the patients, given that breast conservation therapy is not as likely to develop body dysmorphia because you are not removing the entirety of the breast. And so it can contribute to better and so although this was not included in the study, we hypothesized that it is able to lead to better quality of life and better body image than the mastectomy. And it is non-inferior. So in patients who are node positive and have undergone neoadjuvant chemotherapy, or patients who have breast cancer in general who have undergone neoadjuvant chemotherapy, we believe that based on this study, breast conservation therapy is a more than valid alternative to mastectomy alone, given that you are also performing radiotherapy after the breast conservation therapy. Next slide, please. That's it. Thank you.
Okay. Okay. Where do we start first? So let's start with the journal. No? Okay, let's comment on the journal. Thank you for that presentation. Ikaw lang yata nag-present. No? What's that? CNC. Okay. So it seems that the the teaching of Dr. Dance has really helped you in analyzing the journals, right? Okay. It's not easy to analyze the journal based on the evidence-based processes, right? Okay. So you have so many formulas, so many things to remember and to consider. No? Okay. So I'd like to congratulate you for appraising it using the processes, no? The standard processes. So the clinical question is really, can you do breast conservation after a neoadjuvant therapy versus versus a modified radical mastectomy without radiation? No.
Yes, boss.
Now, when you say breast conservation surgery, it's really preserving the breast, not removing the entire breast, but only the tumor with a good margin. No? So that's what is called lumpectomy. No? But you have to add radiation, right? So that's
Yes,
the definition of breast conservation. No? So I have taught you a process of doing problem solving and decision making in terms of selection of paraclinical diagnostic procedure, and also in terms of selection of treatment procedure. Okay, so in this particular journal, we're talking about selection of treatment, right? Breast conservation versus mastectomy. Okay, so you can use the same process. So the same process that I am teaching you, you use the table of BRCA. So that does not stand for breast cancer, huh? BRCA. That stands for benefit. B stands for benefit. R risk. Then cost. C cost. Then A availability. Okay.
Yeah.
So you can see the relevance of this BRCA in your discussion also. Okay. When you talk about applicability, now applicability in terms of applicability to our Filipino patients, other groups of patients. Okay, so the generic process is still to use the BRCA. Now, example will be A. When you talk about A, is it applicable? Okay, in our setting, you talk about I don't know whether in one of your slides in the discussions, no, there was mention of a plastic surgical expertise coming in for the breast conservation, right? Okay.
Yes,
okay, but if that be the case, then the importance of the issue of applicability should be considered. No? Okay. So if you don't have a plastic surgeon who can do it, then right away you have to do the modified radical mastectomy already. No? Okay. Another example of applicability is that okay, this table shows the available services in PGH in many hospitals. No? In terms of radiation therapy, no? There are a lot of centers in the provinces which do not have radiotherapy facilities. No? So if you don't have the radiotherapy facilities, then you cannot do the breast conservation. If breast conservation would entail lumpectomy and radiation, right? Right? Yan?
Yes po.
Yes po.
Yes po, sir.
Those are the two examples that I would like to give to emphasize the importance of using the aid in your decision making. Now, okay, as well as in terms of appraising the applicability of a recommendation in a particular patient. Okay, and also the cost. So the cost probably would be higher for breast conservation. Tama ba? 82.
Yes po.
Yeah.
Yes po, sir.
So because you need radiation, no? Radiation is additional cost, no? Okay. Surgery is just one cost lang without radiation yon, no? Okay. Now, but among the four parameters that I mentioned in terms of guiding you in making a decision to do the problem-solving decision, BRCA, as a priority, you put on the B, no? As a B, on the benefit, no? Okay, then the risk, then the cost, then availability. In that order, BRCA in that order. You put priority in the B, and then after that, the risk, and then the cost, and then the availability. So a lot of times we hear about the risk-benefit ratio. I don't know what was the origin of the term. Probably it's better to talk about the benefit and the risk, not really risk than benefit. No? Because most of the time, the risk is usually acceptable. No, we don't usually talk of we don't propose things which are very risky anyway. No, but we know that every procedure has a certain degree of risk, but most of the time it's really acceptable. No, acceptable in the sense that it's not really life-threatening. No, okay. So, and then as I said, put a lower priority on the cost availability, because sometimes the patient will be able to find resources for the cost. Then also they can transfer to areas where resources are available in terms of applicability. Now, that's why I said put, but you have to consider that in your decision making, problem solving. Okay. Now, in terms of benefit, so benefit here will be if you compare the two, what was not mentioned is the local recurrence rate. Now, as a breast conservation, you just do a wide excision, lumpectomy, and then the reason why you add irradiation, you just want to decrease the recurrence rate. Now, local recurrence, right? You see the rationale for adding the radiotherapy after the lumpectomy. Now,
Yes po, yes po, sir.
Yeah, in mastectomy, you don't add the radiation anymore because you remove the entire breast and then you have a good margin. Okay. So in that studies, I don't know, was it mentioned about the local recurrence rate, or they just go to the cancer-free mortality, cancer mortality free? Walang recurrence rate consideration?
We weren't able, the study didn't look into recurrence rate po, sir.
Okay. So I'm just asking, no? Wala, no? Okay.
Yeah, wala po.
Kasi in patients who, there are also studies that dwell on the non-neoadjuvant, yung mga earlier stages, no? Okay. So those patients who don't need neoadjuvant, they also compared breast conservation versus total mastectomy. Okay. So it has been found that in general, the local recurrence rate will be higher for lumpectomy. So that's why they add irradiation to decrease the local recurrence rate. But still, there's some degree of local recurrence rate in lumpectomy and radiation. Okay. Of course, when you do researches, it's more of statistics. What do you call that? Statistics approximation. No? Some would be significant, that some would be not significant. No? Okay. Now, the other, okay. The overall survival rate, as mentioned, is practically the same. No? The overall cancer mortality rate, as used in the paper, no, the same. No, and then if you, so you don't be contented with the overall, then you dissect it. No? That's why they did it. Whether what are the other risk factors for a recurrence, for a that will affect the survival rate, such as the nodes. No, they mentioned about the nodes, whether it's positive or negative, but they saw no difference also, no? Right, in that paper. Walang difference, di ba?
Wala po.
Kasi a lot of times, although the overall the cancer mortality will be the same, but when they dissect the various patients into various subsets like nodes positive, they might find some difference, di ba? Okay. If nodes are
Sir,
positive,
opo, even for node positive po, not statistically
yeah nga,
significant.
that's good nga, no? That's good, okay? So that's why I said the process is tamang ginawa nila, they dissected it, no? They looked at the other possible risks. Kasi nodes is a very important determinant of failure rate, no? Okay?
Yes.
Okay. So we just have to accept all those, once you get the, ganun yan, kasi once you have a patient, now, you ask the question, pwede bang gawin ang breast conservation which include lumpectomy and radiation or mastectomy? Which one is better? Diba? We always ask that question. No? So we can look at the journal, no? Now in terms of local recurrence rate and then overall survival rate. Those are the two most important things that you look at. Then you dissect the other details. Now, if you can see some more details, now like the nodes positive, nodes negatives, now. Then in the end, you go further and then ipasok na yung BRCA. Now, R, the risk. Okay. So ano yung mga risk? Okay, risk will be risk of radiation. Okay. Surgery halos pareho, no? Risk of radiation, no? Okay, ano pa? Wala na, no? Kasi may additional yung lumpectomy na radiation, no? Okay. And then you look at the cost, di ba? Okay, can the patient afford? And then this is too inconvenient for the patient to go to the clinic, to the hospital every day for the next 6 weeks, di ba? Radiation will entail that, no? Okay. Then the availability of the radiation, no? You check na rin yun, no? Okay. Okay. So that's my comment on that. Again, I want to congratulate you for a very extensive analysis of your presentation of your journal appraisal. But I'd just like to extend it. When you talk about applicability, you input the BRCA and come out with a final recommendation. No? Okay. So when you recommend, you consider the setting of the patients, no? Okay. Availability of resources, no? And then the psychological makeup, okay? If she has a personality or a type of person who want everything done right away without a long treatment, no? Then you might consider just a mastectomy. And then, of course, you have to consider patients who don't like to lose their breast, no? If they don't like to lose their breast, then you recommend the other options, no? Okay. Is that
Yes, po, sir.
okay? So clear? Was my
Yes, po, sir. Thank you po.
was my input clear to everybody? The use of BRCA, the use of how to appraise the journal also. Okay.
Yes.
Let's now go to the.
Thank you po, sir.
You're welcome. Mhm. Okay, let's now go to the case. Okay, in the history, would you like to raise a question of the 25 years? Medyo matagal yan, 25 years. Is it really accurate? Okay, that's one. Number two, if it's really accurate, what happened? Is it a breast cancer to start with that lasted for 25 years? So who wants to give some thoughts, some ano, what's your introspection on this one? So when I see 25 years, ang tagal, di ba? Anybody? 34,
Sir, I think
34 years.
there was possibly it was started as a benign lesion and then it underwent the malignant transformation not recently lang po.
Okay. So that could be a possibility if it's really there. It's a benign one. But based on your study, how often does a benign lesion transform into a malignancy? Diba?
Sir, actually, since it was described as movable non-penetrating, I'm assuming na it's a solid tumor, and for a benign solid tumor of the breast, which is usually carcinoma, it's very, very rare for it to transform into a malignant tumor.
Okay. So that's why I said you accept it with a grain of salt when you do history. History taking is not as accurate as the physical exams. Diba? Okay. So, but okay, once you ask questions, the patients answered you. Now you have to decide is it really accurate? You have to interpret it. No, but if you don't accept it, put it on hold. No, it doesn't mean that you completely junk it. No, okay. So, but you start thinking, was it really there? Baka iba yung nakakapa niya, no? Okay. Baka iba yung nakakapa niya. There are a lot of patients who said, I noticed this breast mass. That's why whenever I ask patients, what is your chief concern? I don't use the word complaint. What is your chief concern? Okay, what's your problem? So when they say I have a bukol sa breast, when I jot down my note on the piece of paper, I usually put quotation marks sa mass, sa bukol. No? Minsan baka hindi naman talagang bukol yon. No? Okay. So then I have to verify it through my physical exam. Kasi sometimes they will point to a bukol, baka hindi naman talagang bukol. It might be a prominent ribs, it might be a xiphoid process, no? It might be a parang prominence lang because of fibrocystic changes, hormonal changes. No? Okay, hindi talagang bukol. That's why in my medical notes, I usually place a open close quotation marks on the word mass, on bukol. Whenever they say that I have a bukol, then I verify it. No? Okay. So this one could be andun siya. Very rare yan. Very rare from a benign one that transform into a malignancy. Diba? Okay. Baka mali lang siya. Baka akala niya 25 years ago, yung hindi siya marunong kumapa, and then yung 2 years, 3 years, let's say 4 years ago, no, nakapa na niya. Baka talagang meron na binaliwala rin niya kasi sabi niya, baka pareho lang yun sa dati. No? Okay. So when it grew to a size that is very significant already, yung 8 centimeters, okay, 8.5, di ba? Naging 8.5 na, no? So yeah, nagpatingin na siya, di ba? Okay. So that's the first question, no? Okay. Then so she underwent, okay, 8, okay. I'm just wondering, bakit 8.5 is your PE on the medical records, and then the ultrasound shows 4 point something lang, di ba? 3 point something.
Sir, maybe we could clarify po na when the patient first went to the OPD or the PGH OPD, parang 8.5 po siya. So not diagnosed at all. Pero yung on admission po, sir, yung nakapapos around the 4 by 3 cm, which is already post chemo na po, sir.
Yung ultrasound niya before the neoadjuvant. There was mentioned in your presentation something like 4.8. Yan. This is before the adjuvant, di ba? It measures approximately 4.8. So which is
Yes po, sir.
so which anong
Sir,
8.5? Anong 8.5 and then 4.8 dito? How do you reconcile the two?
Sir, sorry. I just want to clarify na this breast ultrasound po was done March 18 pa po. The 8.5 po was reported 2 years prior before po the start of the new adjuvant chemotherapy.
Okay, so you don't have records just before the new adjuvant. She had the new
No,
adjuvant 2
sir.
years ago?
Since it was
Yung
9
8.5.
months po, sir, if I remember correctly.
Okay. Anyway, so there's a discrepancy doon, di ba? 8.5. I don't know where you got it now, but okay. So okay, an issue here that I would like to bring up is when you do your PE, you try to approximate the size of the breast mass. Now, approximate naman, you can use a ruler. If not, you just base it on your experience. If this is the size of the mass based on your PE, nakikita mo without the ruler, because of experience, natatansyan ninyo. I have 2 centimeters lang ito, 3 centimeters, 3 centimeters. Or you can sometimes you use your fingers, the weight of your fingers, ipasok ninyo dun sa sa weight of the breast mass, di ba? Itatansya ninyo, no? Okay. So it's acceptable naman when you make your medical recording, you make a approximation of the mass, the size of the mass, no? Usually in terms of centimeters, no? So that's why you just put there about, more or less about. You cannot be accurate, di ba? Okay. So you use that sign in that computer, yung wave sign about 2 centimeters, or you can put the range 2 to 2.5, no? Ganon. Okay. Then you have a patient, let's say, with an ultrasound or other diagnostic test coming in, no? Iba naman yung iba yung measurement, tama? So you expect a different measurement, no? Okay. Now you have to emphasize to the patient now the difference. Now you have to explain to the patient the difference, kasi the patient may ask, bakit ganun yung size niya? Bakit ganun yung size dito sa ultrasound, sa diagnostic test, no? You can just say that it's just an approximation, no? Okay. Okay. So although you won't be faulted for that, but just try your best to make an accurate. Huwag naman masyadong malayo, no? Let's say 4.8 sa ultrasound, you say baka 5 or 3, okay lang yon, no? Pero kung 8, masyadong malayo na yon, di ba? No? So you have to do some explanation. Bakit ang layo yung discrepancy? 8 versus 4, no? Okay. Was it because of the change of time, nag-progress, no? Kaya baka yung interval between your physical exam and the ultrasound, the time of the ultrasound, mahaba, no? Kaya lumaki, no? O lumiit, no? Ganon, no? So do some explanations, no? Okay. But in the end, I guess what will be more accurate to follow will be the ultrasound. Kasi may machine, they can measure, they can easily measure the size of the mass without the intervening soft tissue that you have when you palpate, di ba? Okay. So ultrasound na lang gamitin niyo for that Pero kung minsan nagkakamali pa rin ang ultrasound, okay? But most of the time tama sila, na? Okay.
Yes, sir. Just to clarify po, yung 8.5 centimeters was just, sir, reported by the patient po. So, baka nga, sir, baka hindi po ganun ka-accurate talaga. Baka, iba po yung memory or naalala niya from a past consult.
Ayan, okay. 8.5. Okay, sige. Okay. Yan yung
Malayo po.
mas accurate yung kaya I don't usually spend a lot of I'm not saying waste, no, I don't spend a lot of times on the history. I just say chip complaint, ano yung chip concern mo, may bukol, no? Okay. Kailan mo nakapa? Kailan mo napansin? Ganon, no? Then I go direct to the physical exam already. Thank you. Then I ask more questions, no? Okay. So if I do the physical examination, the confirm ko na there's really a breast mass, then I ask, okay, if I need to know kung malaki siya, sabi ko, yung nakapa mo, ganong kalaki pa noon, no? Ganon. Just ask a little questions, no? But in the end, the present PE will be determining the deciding factor for your diagnosis already, di ba? Okay. Yung mga history, medyo inaccurate yan eh, no? Okay. Okay. So you just pick out those which you think are that will jive with the logical course of the disease, no? Ganon. Okay. Okay. Okay, before I forget, you were using nag-neoadjuvant siya. What's the difference between complete response and partial response? Anybody? Kasi nakalagay niyo, yan, found to have complete response, but there is a decrease in size of the mass. 8 by, from, ginamit yung 8 by 8 kasi, okay. Anyway, kung sabihin natin, tama yan, 7, no? Of 8 by 7 to 4.3, no? Is that a complete response?
Hindi pa po, sir. Partial lang po. Kasi the complete response should be disappearance of all signs of the cancer in the body.
Or complete, baka yung based on the mass, no, wala yung mass. Hindi mo makapana, di ba?
Opo.
Okay. So, it should be, kung meron pang 4 point, after the new adjuvant, there's still a mass there. Right? Mas maliit na. Anybody?
Yes po. Yes po.
So that should not be complete. Na? Okay. So kung lumiit, may response. So when do you say it's incomplete partial response versus no response? There's a standard definition for that. Do you know? Anybody? Anybody? Ira? Ano yung difference between, ano yung, may instances in which lumiit pero less than 50%. Do you still consider that as a response? Yung kung di lumiit, no response, di ba? Kung walang pagbabago. Pero kung lumiit ng konti, no, let's say 10% from 2 cm to naging from 8 cm naging 7 cm, lumiit ng konti, no? So do you label it as partial response or no response pa rin?
Sir, based on my readings po, sir, complete response is disappearance of all target lesions. While partial response po is a decrease of at least 30% po in the size of the tumor po, sir.
How many percent?
At least 30% po.
30% lang? Okay. O sige, check na natin. Di ba 50%? Sa anong reference mo?
Wait, sir. Sa NCBI po, sir.
Okay. Okay, check na lang ninyo, no? From what I remember, it should be 50%, no? Okay. So 50% of the product of the width and the length, di ba? Mina-measure yan no? Okay. Okay. I-multiply mo yung length and the width, no? Kung wala yung, if you cannot get the height, no? So this is not complete response, okay? Do you all agree on that?
Yes po, sir.
So may
Yes po,
residual
sir.
pa. May residual pa kasi, di ba? Meron pang konti, kahit na maliit, no? Okay. Okay. Now, going to the primary diagnosis, no? Okay. After your history and PE, you came out with the primary diagnosis of breast cancer and then secondary diagnosis benign, no? Okay. So you put the okay. Can you there's another way of putting, kung very sure ka na breast cancer siya, now based on the pattern recognition and also the prevalence, you don't have to put the benign one. Kasi medyo malayo naman yun eh. Di ba? You're not thinking of most likely it's also a cancer. So you try to think of a type of a cancer. What type? Because I'm not going to say there are a lot, but there's other types of breast cancer. Okay, so you can have sarcoma of the breast. No, you can have invasive ductal carcinoma. Okay, and others. No, okay. If you know that there are different types, if you know the pattern, you can put there as your primary what you think is the most probable. Let's say invasive ductal carcinoma, and then the second one could be a breast sarcoma. No? Okay. Sometimes it's hard to differentiate the two. Okay, but you have to make a decision, educated guess based on what is more probable. You can put breast sarcoma as number 1 and invasive ductal carcinoma as number 2. Okay, as secondary. No? Okay. Okay. But if you think it's small chance it could be benign, no? Try your best to specify what could be a benign breast cancer.
Fibroadenoma, sir.
Fibroadenoma. Okay. Walang skin changes ito, no? Walang skin changes.
With skin changes, sir, pero nung lumaki na po. Erythema po and nipple retraction.
Okay. Eh, kung gano'n, hindi fibroadenoma. Hindi ganun ang pattern ng fibroadenoma. Kung may skin changes, walang skin changes, pwede. Di ba? Okay. So,
Phylloides tumor, sir.
phylloides, yeah, okay. Phylloides tumor, okay. You specify it, phylloides, no? So try your best to come out with a more specific diagnosis, no? In the process, when you do that, you also learn, now, pag na may biopsy, alam mo na, tumama yung, it turned out to be invasive ductal carcinoma, then sabihin mo, hindi pala phylloides ito. Okay, you learn from the experience, no? Okay, okay. And then, about the certainty of diagnosis, ito yung ano ko ha, because this is not being taught in the textbook, no? So a lot of times when we make decision, we don't put it down on paper, but deep inside our brain, or even in our hearts, hey, I feel na most likely this is it, di ba? I'm not certain, yung mga ganon, di ba? Okay. So, and a lot of times we make decision on sabihin natin, I'm quite certain that this is it. Then we go for it, di ba? Okay. So, ano ang kasi ang susunod ng tanong yan, when you do your paraclinical, you base it on your certainty of your diagnosis, no? Because as a rule, if you're not quite certain, no, you have to go for a diagnostic procedure. If you're quite certain, you don't have to go to, di ba? Okay, that's logical, di ba? Okay, but how do you quantitate? Yan ang palaging tanong sa akin. How do you quantitate the degree of certainty? Mahirap, no? Okay, I've been looking for a answer to that. No, up to now I have not really come out with a very foolproof na answer, no? But this is what I usually do, no? Kasi, okay, yung okay, before I go to the tips on how to quantitate the degree of certainty, now, a lot of times patient would appreciate if you put in the degree of certainty. Kasi we doctors, a lot of time, we also say 50-50 eh, di ba? 50-50 tayo palagi, di ba? Okay, parang uncertain pa rin tayo, di ba? Okay. So, but if they hear that, if it's benign, sinabi mo, 95% benign, masaya na siya kagad, di ba? Kaysa yung from before the patient hears your pronouncement of the degree of certainty, anxious siya, no? Baka cancer ito, baka ano, di ba? Okay. But after the physical examination and history, sinabi mo kagad, before the lab exam, sabi mo, I'm 95% certain, I'm 95% certain that this is benign, na? Parang hindi ka na matakot, na? But you have to remind them, I'm not 100%. Tama sinabi ni Sor, there's no such thing as 100%. Na? Okay? But at least, yung malignant one will be 5% na lang. Diba? Okay? You have to tell them that I'm not 100% certain, but I think we have to study this further. No? Baka kailangan natin gumawa ng diagnostic test. Na? Okay? So it's nice to quantitate some degree of certainty, no? Okay, para to allay the anxiety of the patient. No? Now, yung degree of certainty, if you base, as I taught you, the processes that you use will be pattern recognition and prevalence. Okay, if you base on your diagnosis on pattern recognition, no? Dun lahat, most likely you're quite certain may pattern, na? And then, kung nare-reinforce by a prevalence data, mas mabigat na siya, na? Okay? Then the other way to quantitate the degree of certainty as a rule, you are not if you base your diagnosis on the signs rather than the symptoms, mas mabigat yung degree of certainty mo, okay? Because you base it on the signs. But if you base it on the symptoms only, mas mahina yon. Okay? Okay, those are the general guide. Okay? Now, I just put 90 as the cutoff for the moment. Okay? That's why I said I don't have any hard data, hard basis, no? Pero tinitingnan natin lahat ng mga diagnostic test naman, which include the physical examination, pag more than 90%, acceptable na siya, di ba? Acceptable na siya, no? So, if you're quite certain, just put it at 90, no? If it's less than 90, it's not quite certain, not certain, no? Ganon, no? Okay. So you can use that as a guide to tell your patient, but you have to put a follow-up caveat na ito based on my experience lang, ha? Sabihin mo lang, based on my personal experience, na? Okay. So even for me, I don't want to fault you. Based on your personal experience, if you say you're not certain, but for me, with my experience, I'm quite certain of something, na? Okay, mag-iiba yung pronouncement natin, but I won't blame you, na? Okay, I just wish that after that experience, you might learn from it, and then next time you see another patients like this with the same signs and symptoms, mapalitan mo na, okay? Mas alam ko na, okay? Mas certain na ako, ganon, no? So that's how I learn also from practice, no? Okay? So 90% will be the cut-off, but you can go as high as 99. Hanggang 99 lang, huwag kayo aabot ng 100. Na? Okay? Okay, sabihin nyo hanggang 98 kung gusto nyo. If you put it 99, based on the evidence-based recommendation, evidence-based medicine recommendation, pag 99 ka na, wala ka ng leeway for a paraclinical diagnostic procedure, di ba? We do paraclinical diagnostic procedures only if it will increase our degree of certainty. Tama? Yan ang sabi ng evidence-based medicine processes, di ba? Tama ba, Sian? Sian?
Yes, sir. Yes,
Tama?
sir.
Okay.
Yes,
Kung
sir.
gusto mo pang, kasi there are instances in which you have to do a paraclinical diagnostic procedure even if you are quite certain. Na? An example is that when you have to do a mutilating operation, kahit na 95% certain ka na, very mutilating kasi operation, big operation, you have to increase it up to 98, 99. Na? So that's the justification for a paraclinical diagnostic procedure in the event that you're quite certain of your diagnosis. Na? Okay? Okay, any question on that quantification? Wala? Any question? Am I correct in
None po,
saying
sir.
that? Am I correct in saying that most of the time yun ang ginagawa natin, di ba? In gut feel, I'm quite certain. Kaya lang din yun nilalagay sa paper. You don't convert it into numbers, di ba? Okay. So, na-appreciate ng mga pasyente yan, na? Okay. Pero pag kung certain ka kang malignancy, huwag mo kagad sasabihin na now you have to size up the psychological makeup of the patient kung kaya niya tanggapin. Now you have to talk to the relatives first. Na? Okay, before you tell the patient na ang diagnosis ko dito, no, 95 99% certain na ako cancer, pero kung mabibigla siya, di ba? Okay. Huwag niyo sasabihin kagad muna, na? Okay. So, i-modulate lang ninyo, na? Okay. Do you have any questions? I'm looking at my notes pa.
Parang wala po, sir.
Wala kayong tanong? Bakit ako maraming tanong? Etong okay, not in that order anymore, ha? Wala nang ordering ito. Yung T4, yung clinical, yung staging ninyo, I can see in your presentation, sometimes you put their M0, sometimes you put their MX. So what will determine what you put there? M0 and MX. M stands for metastasis. So when do you use MX? When do you use M0?
MX po, sir, if there is no workup yet. And M0 if there's no clinical findings or radiographic findings po of metastasis for the patient.
Okay. Or as a clinician, anong ginagamit natin?
Sir, parang it's more appropriate to use the M0.
M0, di ba?
Yes, but since the table, sir, sabi is clinical findings or radiographic findings, and since the patient doesn't present with any clinical findings of metastasis, he will fall for M0 na po.
Okay. So use M0 as clinician, no? Yung MX, I think it's coming from the pathologist. Tama? MX? Okay. Kasi hindi naman sila clinicians, you know? Okay. So they just base it on the report that you just submitted your nodes and also your breast tumor. So they don't have a way to determine yung M. Now, so they put X. Now, but for the clinician, we have to use not X, but M positive or M0. Now, okay. Now, yung M, how do you assess the M in terms of clinical, kahit na wala pang lab? So you can ask questions, no? Aside from your PE of the breast and also PE of the whole body, no? You can ask additional question. Do you have a frequent headache, no? For a long time, no? Kung positive siya, then you may have to consider possible brain metastases, no? Okay. So you ask questions along the line of the more frequent sites of metastases from the breast cancer, okay, which is the brain, the bone, the lungs, ano pa? The liver. Yung
Liver po, sir.
Yung apat, no? So you ask questions, do you have frequent cough for the past 1 month, 2 months, hindi nawawala, no? Okay. Kung meron, kung positive, even without the X-ray pa, kasi ito yung clinical staging ito, you can put there M1, possible lung metastases. No? Ganun din, bone pain. Do you have bone pain for a long time? No? Then, kung negative, the M0. Diba? Okay. And then yung abdominal pain, especially on the right upper quadrant, to check for liver met. No? Okay, kung may pain siya doon, then pinalpate mo, no? Kung wala kang mapalpate, but patients complains of that pain, frequent persistent pain in that area, then you can consider liver mets, no? Okay. Okay. So those are the things that we also do in when you do a surveillance. Okay, let me jump to the surveillance. After the operation, you have to make surveillance of breast cancer patients. No? So you do two things or three things. There's such thing as symptom-based surveillance, just based on signs and symptoms. Okay. The other one is based on a battery of tests. Now you do a lot of CT scan, ultrasound, now, and then bone scan to check whether there is metastasis or recurrence. Now, but if you use the symptom-based approach, you just ask the questions: do you have frequent bouts, persistent bouts of headache, persistent headache, persistent bone pain, persistent abdominal pain, persistent cough? Kung wala, most likely negative siya. No? Okay. Then do your PE, physical exam of the breast, of the chest, and also the axilla, and also the liver, and the upper abdomen, and also on the neck. Okay. So that will complete your basic examination of a patient under surveillance using the symptom-based approach. No? Okay. So the other approach that you know of, which is frequently done, which is not usually advocated also, no? Aside from mammography, no? Yearly mammography after the operation, di ba? After the treatment, they do a lot of bone scan, CT scan, on a yearly basis, no? Okay. So these are usually not cost effective, no? That's why ang recommendation is really to start with the symptom-based surveillance. If you suspect something, sabihin natin, palaging may masakit ang bone niya, that's the time you do the bone scan. Huh? Okay? As indicated. Okay? Okay, nasaan? Yung surveillance? Yeah, that's part of the prevention, no? Psychosocial imaging. And then, okay. Yung sa psychosocial concern, yeah, so, ang i-add ko lang dito, okay, I have a note here on the psychosocial concern mo. You have to educate your patient and then try to convince them to accept the fact that they have cancer. A lot of times, okay, di nila na-accept no? Okay. And also, try to be a life coach also. Coach in life, no? Not telling them frankly, but that making them realize that there's a limit to our life, no? And then wag yung mga you have to accept the fact that one day we're gonna lose some parts of our body. We want to die with a perfect body anyway. Diba? What's more important is that we are functional. No? Okay, you have to coach them. Kung wala, maraming gagawin yan. Maraming hahanapin yan. No? Okay, which will make them unhappy also. Okay. Kaya yung mga nagpapa-breast reconstruction, no, kadalasan, they don't accept the fact that they're gonna lose it anyway. No? Okay. Okay. Okay, going back to yung slides on yung CNN, NCCN ba yun? NCCN, age 30 and above. Can you go back to yung that table? Okay, age 30, diagnostic ultrasound. Ang recommendation nito, no? Diagnostic mammography and ultrasound, and then core needle. Okay. So in this particular patient, if you were handling this patient, you were able to palpate the mass. Sabihin natin, with all the clinical signs of skin changes na. So what will you do? Are you going to do all of these things? Patingin nga yung table na yung may diagnostic procedures. Yan. Sige. So which one will you do first? Or kahit na dalawa. Sige. If you were the one who saw this patient for the first time, wala pa
Pero
siyang
ano,
wala pa
I
siyang
think
ultrasound, wala
ultrasound.
pang mamo. Wala pa siyang ultrasound, wala pa siyang mamo. Ha? Nakapan na lang ninyo. Okay, anong gagawin ninyo?
I think ultrasound first, sir, since quicker and readily available. And then depending on the findings, sir, like for this one, it's BIRADS 5 already, so highly suggestive of malignancy. I think based on the footnotes din po sa NCCN, we can opt not to do the mammogram anymore since it's a nearly definitive finding, sir. So we can proceed agad to core needle biopsy to confirm the suggested findings of the ultrasound, sir.
Okay. So, okay, usually after your diagnosis, sabihin natin na primary clinical diagnosis, breast cancer, you're more than 90% sure, no? Kasi malaking-malaki na, may skin changes, but you're gonna advise the patient what will be done next, di ba? Sabihin mo, now we will try to decide what we need more diagnostic procedure if that's your decision, no? So what are the options, no? Okay. Options 1 will be all of these mentioned here. No? Okay. Pero okay, offhand, tanggalin na lang natin muna yung immunochemistry. No? Because what we are after here, the goal is when you do your paraclinical diagnostic procedure, you want to firm up your primary clinical diagnosis. No? Okay. Not the treatment yet. No? Okay. Okay. So you want to firm up, you increase pa yung 90% to 95 to 99%. Na? Okay. So the immunochemistry is just a guide. Hindi kasama yan dyan. Na? Hindi kasama sa table yan. Na? Okay. Now, what you can add, of course, there are others that you can do, like a lot of doctors are doing CT scan right away, ba? MRI. Na? So you can put there as one of the options. When you put down as options, for you to discuss it with the patient. Yes. Okay. So a lot of patients now, because of the practices of a lot of physicians now, they're expecting something else now. So ililista mo lang and then tell them why it's not needed. Why, let's say, why CT scan is not needed, why MRI is not needed, why thermography is not needed. Meron pang maraming test yung ginagawa, no? Sa Pilipinas, sa buong mundo. Even in the future, marami yan. May bagong lalabas yan. Na? So you have to list down the options, na? And then explain to them what is will be recommended based on the benefit, risk, cost, availability. Na? Okay. So just stick to this 3. Pero yung number 3 mo, have you heard about the needle aspiration biopsy?
Yes, po.
Po, sir.
Bakit hindi nyo in-include dito? Because yan ang ginagawa ng PGH.
Sir, with core needle kasi you have a higher yield po.
And then we're talking about options. Options mo na. Mamaya i-ano natin. I-dissect natin sa benefit. Pwede yung needle, fine needle, di ba? Tama? Stephanie? May?
Yes po, sir.
Okay.
Pero mas
I-compare mo mamaya. Let's say, ilagay mo yung mammography, ultrasound, then actually, pwede ding pwedeng open biopsy, di ba? Tama? Open biopsy, pwedeng fine needle, pwedeng core needle. Okay? Pwedeng options for frozen section, di ba? Biopsy. Okay? So this is in the stage that you're advising the patient already. What will we do next? What will we do next to increase our degree of certainty? Di ba? Okay? So i-compare mo yung mga ito. Mammography, okay. Offhand, you just do this such a general comparison. Pag biopsy, in terms of benefit, mas greatest yield siya because it's a direct examination. I'm not talking about the type of biopsy yet. In general biopsy. And then the ultrasound and mammography are indirect examination because they're imaging procedures only, di ba? Okay. And then if you have to dissect yung the type of biopsy, okay, that fine needle biopsy carries a 90% degree of yield, di ba? More than 90%. Let's say 90%. Core needle will carry a higher yield, probably 95, 98. No? You just have to, it's based on the experience of a particular center, but kung minsan, depende dun sa gumagawa, no? Mas magaling, based on his experience, no? He gets a 95% accuracy, then sasabihin niya, no? And then open biopsy, frozen section, mga 98%. Diba? Okay? So between a core biopsy and open biopsy, mas reliable yung open. Tama? Okay? So if we just base it on the most reliable result of the procedure, you would choose an open. Pero why is it not recommended? Diba? Yan ang tanong. Diba? Okay. So you really have to consider the risk, the cost, availability, and also the practicality. No? Okay. So ito lang tinuturo ko yung process. You list down the options and then try to compare the benefit of each one. Okay. Okay. And then the risk, the cost, availability. And then you try to assess the patient's psychological makeups. Kasi pwedeng pwedeng sabihin ko, one practice could be, I can tell the patient, let's do the needle biopsy na lang ngayon. Madali lang. No? I can do it now in the clinic. No? And it has a 90% yield. No? Okay? You don't have to go for an ultrasound. No? Ganon. No, kung ayaw niya magpatusok agad, no? Okay? Then she says, he would choose na breast ultrasound muna. No? Okay? And then, Dr. Mendoza, you mentioned that NCCN does not recommend mammography.
It recommends, sir, although there was a footnote that said if the findings on ultrasound are already suggestive of malignancy or kung ano, sir, parang or on the other end of the spectrum naman, cystic daw po. Parang they recommended to na you can opt not to do the mammogram, sir.
Okay, I'm glad that you mentioned that. I'm not familiar with that statement findings, no? Pero it jives with my practice, no? In the Philippines, they always do mammography and ultrasound together, di ba? Okay. Pero to tell you, this is based on my experience, sharing with you my experience. I would prefer ultrasound over mammography if I have to do one, especially if there's a palpable mass, no? Okay. A lot of times, more than 99% of the time, when you do a mammography, you can expect, you have a statement down below in the report, BIRAD 0. Palagi, how long have you seen mga mammography results na? Marami na kayo nakikita? Marami na kayo nakikita? Wala pa.
Not so many po, sir.
Okay, pero makikita ninyo, you validate my observation. No? I've been in practice for the past 40 years. Now, mammography results, they always put there, BIRAD 0 pag walang ultrasound. No? BIRAD 0 means needs additional test. Tama? Okay? And I'm questioning that practice of the radiologist. No? But in the main report, sa loob ng report ng mammography doon, sasabihin nila, no evidence of microcalcification, clusters of microcalcification, no thickening, no structural deformity, ganon, no? Okay. So that enough will be negative, di ba? So based on the report, negative. So but they always insist on putting a BIRAD 0. They don't like to commit. No? So they should put their BIRADs 1 or BIRADs 2. Diba? Okay. So in contrast to the ultrasound, 99% merong birads, no? Walang zero. Okay? So kung ganun pa man, mas maganda na rin yung ultrasound, di ba? To be practical about it, di ba? Okay, so magpa-ultrasound na lang, di ba? Okay. So that's my input on the community practice, no? Okay, which will not be seen in the books, di ba? Okay. So ultrasound, when you do an ultrasound, okay, it can give you some information, ill-defined border, circumscribed as mentioned by sino by si Mayba. When it's well defined, more or less, it's benign. No? When it's cystic, it's benign. Okay. Okay. When it's solid, pagkatapos merong mga ill-defined borders, in this particular patient, speculations, no? Yun, Byron's 5 na yun, no? Byron's 4, no? Okay. Okay. Now, the other drawback with the ultrasound, kasi very subjective siya, no? Okay. A lot of times, you have a reading of 4, no? Okay. And then, kahit na wala kang nakakapa, no? May mga readings of 4 ka, yun ang alarming, no? Okay. So as I said, the ultrasound reading by these ultrasonographers is very subjective. They try to say they try to overread, no? Okay. So kung sinabing 4, I usually have it repeated by another center kung wala akong makapa, no? Okay. So I'm talking for another scenario, hindi itong pasyente nito, ha? The use of the ultrasound. So kung wala akong nakakapa, no? Tapos Byrad's 4 sinabi niya, 4 is suspicious. I usually have it repeated in another center. Okay? But not telling the center that nagawa sa labas. Nagawa na. Para may second opinion. No? Kadalasan, from 4 nagiging 3. No? Ganon. Okay? Now, pag may nakakapakang bukol, that's another story. No? Okay? So you accept talaga may bukol, tanggapin mo yung just rely on the readings. No? Pero kung wala kang nakakapa, Byrad's 4, marami dyan, Byrad's 4, and then sasabihin nila, recommend needle biopsy. Okay. So anong nangyayari dyan, ang dami na napapa-needle biopsy, kung di naman kahit hindi kailangan. No? Okay. Okay, the other thing here is the terminologies of the ultrasonographers, they usually always use masses or nodules, masses, na? Okay, kahit na walang bukol, na? Try to look at the ultrasound report that you can get hold of. Maraming nakalagay na masses, pero wala kang nakakapa. Okay, so not all masses as reported by the ultrasonographer are really masses, na? So kadalasan, dapat may nakakapa ka, no? Kung wala kang nakakapa, pwede rin tama sila, pero baka maliit na maliit. Na? Pero a lot of times, yung fibrocystic change, when you say fibrocystic changes, it's hormonal changes. There's no dominant mass. Yung fibrous part of the change in the breast will come out as a solid mass. Okay? So they will report it as solid mass. Kaya sasabihin nila, bukol, Byrad's 4, ganon, no? Okay. Okay. So take note of that, no? Okay. Yung mga interpretation of this ultrasonographer, no? So before we leave this topic, needle biopsy can be done, core needle. The only advantage of the core needle, it can give you a tissue biopsy, tissue result, tissue histopath, no? Okay. Questions? Pwedeng fine needle, ha? Okay, let's go to the pre-treatment diagnosis. Pre-treatment plan. Sino ba nagpresento? Si Karel, ikaw ba?
Yes po, sir.
Bakit to reduce the size lang? Tanggalin na nga. Bakit hindi kayang tanggalin?
I was thinking step by step, sir. So initially to reduce, and then the next is to cure, and then the third is to prevent. Parang step by step, sir, na goal. Parang ganun po. One goal at a time.
Yeah, why to reduce? Why not to remove?
Initially po, it was parang inoperable kasi po after at like the 4 with
Okay.
CM.
During
Opo.
during that stage na inoperable
Yes
si
po.
Con. Okay.
Yes po. Yes po, sir.
Okay. Kaya may to
Yes po.
reduce. Okay. To reduce and then to cure. Okay. Okay, ganun yun sa usually yung mga breast cancer patients, no? When it comes to goals of treatment, you decide right away, is it curative goal or palliative goal, no? Okay. So, kung advanced stage nito, 3A, 3B, okay, or metastatic already, it's palliative goal already, di ba? Okay. So, but yung mga earlier stages, then you aim for a cure, okay? But strictly speaking, you cannot guarantee cure also, di ba? You hope for a cure, no? Okay. So just take note of that. When you have a patient with a different stages or with a stage of the disease, now you decide already whether it's a palliative goal or curative goal. And then you spell out to the patient what you're going to do in terms of huwag mo nang gamitin yung cure, to control na lang. To control na lang. Kasi you cannot, don't promise to cure. Okay.
Okay po.
Control the cancer. Okay. And then to
Sige po,
prevent
sir.
the recurrence. Okay. Now, in selection of chemotherapy, you mentioned about the chemotherapy, no? Okay, sige. I-flash mo yung chemotherapy.
Next slide, please. Yeah, next slide pa. Yung.
Sige pa. Yung, okay. So, yeah, the other one. Okay. So, yung benefit, risk, cost, availability, the way to do it, you compare the, kasi there are various regimen of chemotherapy. This is not the only one. Okay. It started with the CMF, cyclophosphamide, methotrexate, and 5-FU. That's the original regimen. And then you have all this new regimen coming out. Okay. So you have doxorubicin, cyclophosphamide, and then paclitaxel. Okay. So you compare the various regimen now in terms of benefit, risk, cost, availability. Okay. Ako ba?
Yes po, sir. Yes po.
So in the end, of course, every new things usually sasabihin niya in favor of the newer ones. Ito, magandang response. Okay. Pero kung minsan, using the BRCA, hindi kakayanin ng pasyente yung cost na 200, 120,000. Tama? Okay. So, you can fall back on the original, yung CMF. Okay. So, what were published before, as I said, is not totally useless. Okay. Pwede pang gamitin yung mga dati. Okay. So, if you fit in mo lang yung situation, kung minsan di kakayanin ng mga pasyente, yung cost that it's not available, yung mga mamahalin ng gamot, okay, then you can use the CMF. The CMS will cost you only about 2,000 pesos per session. Okay. So, kung di siya umubra, you can also use a trial basis. Umpisa mo sa pinakasimple. Kung umubra, well and good. Diba? Kung di umubra, then you can go to a next higher level of regimen like doxorubicin, ganon. Okay?
Yes po, sir.
Okay, probably the last one na lang. Okay, kasi it's already 12. Nakita niyo yung breast. Paki-flash yung nga yung breast. Yan. It stimulated me to think that ina-expect mo, kung ano yung malaki, you say ando yung bukol, di ba? Ito, mas maliit itong breast niya ngayon sa left side, di ba? How do you explain this? Mas malaki ito, kasi kung wala kang drawing, I was expecting baka andito yung bukol, di ba? Okay. Pero how do you explain this? Andito yung bukol niya, pero mas maliit ang breast niya. Tanggalin muna natin nipple retraction kasi may clue na may bukol siya doon. I've been teaching patients or even students that it's better to palpate, no? Kuminsan it's hard to make a conclusion just based on the ano, baka talagang asymmetrical sila to start with, na? Okay. Or may bukol siya rito, baka kasing laki noon as the other side, but parang kinocontract ng bukol, lumiliit yung breast niya. No? That's another way of looking at it. No? So, were you able to see this patient before the operation? Okay.
No,
that's
sir.
the
Pictures lang, sir.
Pictures lang. So that's the explanation. Bakit lumiliit itong breast? Because kinocontract hinihila ng breast cancer. No? Okay. So, but in other situations, I would really expect andito yung bukol niya when I see an equal breast. No? Okay. So just a comment on that. No? Okay. So the important thing there is to palpate the breast. Okay. So any questions? Any questions before we end our sessions? Wala? You want to ask me questions?
Sir, doesn't PhilHealth cover chemotherapy po?
It does. It does. Why do you ask?
So regardless of regimen po, PhilHealth will cover it. Will it cover the entirety of the regimen or only part of it?
Number one, nakikita ko sa breast care center, you have to have an approval of the PhilHealth, na, regardless of the regimen that you're going to use, na. And then, ang tanong mo, the question is kung masusustain. Kung walang stocks, no, it's either the patient will have to wait for the next cycle or a lot of times the residents usually advise them to buy na lang, to buy on their own para hindi maputol yung hindi ma-delay, na? Okay. So but strict speaking, they should cover, na? Okay.
Thank you po.
Okay. Any other concern?
Sir, based on your experience po, sir, which do you prefer po? To do FNAB po or core needle biopsy na lang po kagad?
Okay. Alam mo yung history ng PGH yan, GS1, history, because I've been with the GS1. We started with a fine needle, needle biopsy. Pero after a while, we saw that a lot of our residents, usually yung results nila, non-informative, hemorrhagic, ganon, na. Then we shifted to core needle para hindi na tusok ng tusok, paulit-ulit. Na? Okay. But for my personal practice, I can do it well. Na? Okay. In fact, I have a batting average of 98%. Na? Okay. Then, when the patient comes in with a breast mass, which sabihin natin, hindi pa sure kung cancer or hindi, cancer, hindi pa sure, let's say, less than 90%, no? Okay. So I would do a needle biopsy first, fine needle in my clinic, kasi magagawa ko sa clinic agad yan, 2 minutes lang, no? With a 98% accuracy. Then, the results will come out right away na in 2 days time, 3 days time, or within 1 week, na positive or negative for malignant cells. No? Okay. Whereas if I have to do a core needle, it's either I prepared my clinic with the instruments and doing it there, or I have to do it in the operating room. So I have to have another schedule. Not, okay. So with the yield that I'm having, and also with the cost for the patient. Kasi yung cost ng core needle, strictly speaking, mas mahal yon, di ba? Kasi may instrument yon, di ba? May equipment, no? Okay, kung sa government, baka libre, di ba? Pero kung sa private, you have to spend for the cost of the needle, the core needle, no? Ganon. And then the other advantage, if I can have a quick results, no? This is the new advantage that I discover, which I'm using now. Pag may reading ako ng positive for malignant cells, no? And then the patient is less than 60 years old, no? I right away I gave them a certificate to ask them to proceed to DSWD to get a PWD benefit, na para pagdating dun sa major operation of mastectomy, they are already covered by the 20% discount for the PWD, na ganon, na. Okay. But okay, your question is pertinent because I don't know whether I'm the only one doing it here in Manila. No, okay, a lot of doctors, centers are doing core needle already, di ba? They have shifted, no? Sa thyroid, fine needle pa rin, di ba? Sa thyroid, no? Okay. It's only on the breast, core needle, no? Okay. But in the
Thank you,
province, I think you can do the core needle if you don't have the fine needle, if you don't have the core needle equipment, no? Okay. That's why papasok yung BRCA mo palagi, no? Okay. So yung BRCA will justify your whatever decision that you make, no? Kasi pag wala kang BRCA, you always stick to ano ba yung recommendations, ano ba yung dapat gawin, ano ba yung ginagawa ng lahat, no? You don't have to follow, no? Okay. So you just use the BRCA to justify your decision, no? Okay. You can use the so-called second best, pwede, di ba? Second best, but you can achieve the same results, no? So fine needle biopsy, let's say turn out to be CA, so imamastectomy ko, and then that's time lalabas na yung mga histopath, lalabas ang ERPR, no? Ganon, no? Ang advantage ng core needle, you can do the ERPR test already before the operation, di ba? Okay. Pero may bayad yun, di ba? So i-fine needle ko muna, document is CA, and then make the patient avail of the PWD already, di ba? Okay. Any other questions?
Thank you, sir.
You're welcome. Meron pang tanong? Paano ba pagtanggal ng share screen ito? Ayan, nasa iyo pala. Okay, if there are no more questions, it's almost 12:30 now. Let's have a group picture. Sige, group picture na tayo bago po makalimutan. Ian, Black.
Ay po, sorry, nakabita
Okay.
lang po ako.
Baka natutulog ka.
Hindi po.
Okay, let's have a group picture together. One, two. Try to get a picture also on your side.
Got it po, sir.
Okay, no more questions. We'll call it a day. Yung form, andyan na sa ano, no? Nasa chat box ninyo. Okay. So when can I have the answer? Tomorrow? Pwede? And then the other thing that I'm sorry, I have to make some requests from you. Yung evaluation, your evaluation, I have to give you a grade, right? Okay. I will wait for that. Ito yung olete that I'm asking you to fill up. Number 2, although this is not my standard practice, pero nakikita ko nawawala yung faculty evaluation, no? Okay. So can you fill up the faculty evaluation as soon as possible? No? Okay. I need the faculty evaluation to improve my teaching also, di ba? I've been doing that, no? Pero nakikita ko yung in the past, walang nagsasubmit, no? Okay. So paki-submit na lang as soon as possible so that I can, that's the time I will give you the grade. No? Okay? Okay lang?
Okay po, sir.
Sige. Okay. So 12:25, tapos na tayo. On time. So feel free to communicate with me sa Viber. Okay? Or sa Facebook if you have Facebook. Okay? Thank you.
Thank you, sir.
Bye-bye.
Thank you, sir.
Thank you, sir.